and thresh out some practical points for our audience. And I'm told that there are about 300 students and faculty members and practitioners listening to our webinar. So let's see if we can give them some practical tips as to manage a CML on a day-to-day basis. So can I share my screen, guys?
Yes, sir.
Okay, can you see my screen?
Yes, sir.
Okay.
Yeah.
So let me introduce my panelists to you. Dr. Lalit Mohan Sharma is a very dear friend of mine from Jaipur. We do lots of conferences and lots of projects together. Lalit is senior consultant, medical and pediatric oncologist at the Bhagwan Mahavir Cancer Hospital in Jaipur. We have Dr. Sandeep Shah from Ahmedabad. Sandeep has figured in a lot of CML studies. He has several publications on CML to his credit. He is presently senior hemato-oncologist and medical oncologist at Sterling Cancer Hospital in Ahmedabad. We have Dr. Shekhar Patil, senior medical oncologist at HCG Cancer Center in Bangalore. Dr. Sameer Tulpure from Bombay, senior consultant and clinical hematologist at the very well-known Kokilaben Dhirubhai Ambani Hospital in Mumbai. I think Dr. Somia from Calcutta will join us subsequently. Dr. Rahul Bhargav, my dear friend from Delhi. He's director and head of hematology and hemato-oncology, and he's a stem cell transplant expert par excellence. He presently works at the Fortis Research Institute in Gurgaon. Dr. Shirish Alukar. Alukar is a very dear friend of mine. Some 30 odd years back, we trained in medical oncology in Tata Hospital together. And I have some very, very fond memories of Shirish and myself on the 10th floor of Tata Hospital where we used to stay. He is senior consultant at the Apollo CBCC Hospital at Ahmedabad. And last but not the least, Dr. Sada Shivdu, additional professor and head of the Department of Medical Oncology at the prestigious Nidam Institute of Medical Sciences in Hyderabad. And there are the maximum number of CML publications from our country are from Dr. Sada's institute. So I hope my panelists will permit my gray hair and my age to address them by their first name. And let's quickly start the panel discussions. Our first case is a 31-year-old MD in pediatrics. He is senior resident in pediatrics. This is an actual case. Came in April of 2016 with high-grade fever. He had a CBC done which showed high counts, and a small spleen, BCR-able of 81%, low focal risk diagnosis. We counseled him for a second-generation TKI, but he opted for Imatinib, so he was started on Imatinib. He had an excellent and optimal hematological and molecular response. He's presently on 400 milligrams of Imatinib. Absolutely no side effects other than the fact that he's become several shades fairer, and he's had a deep molecular response. So this is his molecular response chart. I don't have a BCR after this, but you can see that in just about a year and a half's time, he had a deep molecular response. Now, fortunately, this young man got selected in the Rajasthan Public Service Commission to be assistant professor in pediatrics. As is customary, all people joining government service have to go through this medical board. And now you are the convener of this medical board. And my question to you is, would you recommend to the government as convener of the medical board that this young man is fit and approved for government service, or that he has chronic myeloid leukemia which can come back at any time, and he is not fit to join government service because this is a high risk situation? And your neck is on the line, because if you approve this gentleman and that he is disease free and he has a relapse, then you are going to be in serious trouble and there might be an inquiry instituted against you. So let me ask this question to Dr. Rahul Bhargav. Rahul, what would you do in a situation like this? You are the chief of the medical board. Would you okay this man, this
Yes,
young
sir.
man? Yeah, go ahead.
So we will clear the person saying patient is fit, because the whole thing is at this present moment of time he's in CML CP with a deep molecular response. Though the response is 0.0197, still not into MR 4.5, nearing towards MR 4. But the whole idea is his chances of achieving an MR 4.5 and thereby his chances of getting converted into AP or BC is practically zero. So I would not bother about it, and I will say he's fit.
Very good. Dr. Sada, you work in a government hospital, and this might be a usual, maybe not a usual situation, but this situation can arise for you on Monday morning. What would you do?
I think what Bhargav said is correct, sir. Because
Sada, can you just speak a little loud? Your audio is not very clear.
yes, sir. Hello, is it okay, sir?
Yeah, yeah. Speak as loud as you, as loud as
As
you.
Dr. Bhargava said, I think it's right, sir. I think this person is fit to any government job because this is under control. Nowadays, I think the longevity of the CML patient is as normal person. Okay, so if we have something good monitoring, so there is no doubt in that. Only thing is what you said is something like any the cost of the treatment in the future. Most of the government people they say something is cost of treatment is borne by the government. I think like any diabetes and hypertension now, I think all these disorders are like chronic disorders. So we can't just make him unfit for the job. So definitely we can do the fitness and we can mention that then we can live longer. At the future, you know, we can go for TFR studies are there. I think we can convince any government official based on this. So I am saying fit.
Very good. So this actually situation happened with me. Of course, I will not share the identity of the gentleman, but I also did what both my panelists are saying. I declared this patient fit. I'm very happy to tell you that he got selected and is now a faculty in one of our medical college hospitals. Anyone of my panel have any comment on this? Anybody? One quick comment, then we can move on to the next case, or maybe a little bit of theory on this and then the next case.
So Dr. Hemant, the only thing Dinesh and everybody has spoken, the role of TFR and so on and so forth. But my opinion of choosing a medication is of a second line TKI is our ability to prevent even one person going into blast crisis. The data is very clear. People who achieve MMR still has got
Rahul,
9.
Rahul, pardon me for interrupting. We have a case which will discuss that. Huh? Maybe I will take your opinion that time. So, you know, there have been at least two publications, one from the JNCI and one the JCO, in which it is very clear that the survival of patients, whether they are males or females, whether they are whatever age group they are, 55 years, 65 years, is now close to the survival of the people in the general population who are not patients. So I think with expert management, we have been able to do this, which has been a huge advance in the treatment of chronic myeloid leukemia. And the mortality now is driven by the comorbidities which the patient has and not by the chronic myeloid leukemia. So let's come to case number 2. We have a 38-year-old farmer, 4-month history, large spleen, high counts, high platelets, few blasts, raised basophils, raised eosinophils, and the standard CML marrow, Philadelphia chromosome positive, BCR-ABL positive. So final diagnosis of CML chronic phase, high SOCAL risk, and intermediate ELTS risk. So, ladies and gentlemen, I'd like to emphasize to you that in addition to the SOCAL, we should now also get into the habit of at diagnosis calculating the ELTS score, because in the TKI era, this is the score which gives you the maximum survival information. So now my question first to Dr. Sandeep Shah is that in addition to usual hydration, allopurinol, hydroxyurea, what treatment would you start on this patient? Imatinib standard dose, imatinib high dose, dasatinib standard dose, low dose, nilotinib, bosutinib. Sandeep.
I think this patient was diagnosed in 2014 or 16. So
Sorry, Sandeep,
that time,
can you speak up? You're a little loudly, please.
this patient was diagnosed in 2014 or 16, I think.
Yeah.
So that time, generic Dasatinib was not available. So probably I will start him with Imatinib 400 milligram standard dose and see the early molecular response at 3 months. And then I will decide for the treatment.
Okay, so Lalit, you understood the case. How would you approach this patient today? Suppose this patient comes to you today, now.
Yes.
How would you approach this patient?
Sir, I'll be having preference for the second generation TKI and preferably Dasatinib in modern era because the patient has got high so-called score, so we need to hit hard. And second thing, we need to be having a target of achieving TFR, at least a possibility in our mind. So
Okay.
I'll be going for.
And your choice of drug with the second generation TKI is all the agents, at least the three agents, Dasatinib, Nilotinib, and Bosutinib are available to you.
Yes.
What would you choose?
Dasatinib because of the convenience, sir. Otherwise, we have used more of Nilotinib because of the various support programs by the company.
So Lalit would choose Dasatinib because it's an MCure program and they have a generic Dasatinib. Is that right, Lalit?
I think that's not right, sir. It's convenience as well.
Yeah, I completely understand that. That was a below
Yes.
the question.
Yes.
Shekhar, would you agree with Lalit or do you have a different opinion? Shekhar, are you there? Can somebody unmute Shekhar, please? Dr. Shekhar Patil, are you there? Kalpesh, is Dr. Shekhar online?
Yes, sir. He's online.
Is he unmuted? Shekhar, can you hear me?
Hello.
Yeah.
Hello?
Can you speak up, please? We can't hear you. I can't hear you.
Hello. Are you hearing me, sir?
Yeah, we can hear you, but please speak a little loudly.
Yeah, basically, I agree today because of the availability of the generic Dasatinib, I would consider that one because with Imatinib with 400 or 600, the chances of achieving deep molecular responses or long-term remissions with high so-called score are less. So I would definitely consider Dasatinib today with the availability in the generic form.
Do you have a different opinion? Like you work in a hospital where they're all rich patients, there are no economic considerations. Samir?
Sir, given the hospital's name, I think it's a misconception that everybody can afford treatment here. So I think so. To begin with, I would agree with what the panelist is saying, that he's a young person, high so-called score. And as Dr. Bhargav as well said, that the aim should be to prevent going into a blast crisis. So I think I would prefer a second generation here. Now, between Dasatinib and Nilotinib, having used both of them, the incidence of pleural effusions and things, at least when I've used, are slightly higher. Requiring changing of medications. So if someone can afford both, Nilotinib is what I would probably go for because I haven't changed them too much. Okay. I think Rahul wants to say something towards this.
Yeah, Rahul, very quick comment, please.
So, Dr. Samir, I completely agree with Dasatinib, with Nilotinib. That is also troublesome. It is not also such an easy drug. You tend to develop diabetes. So young patient has developed diabetes.
Yeah.
QTC prolongation and so.
Rahul, your audio is
on Nilotinib also one of our patient has developed heart failure. So I think it is often. So can you hear me now?
Yes. Yeah.
You have a.
Yes, certainly there's a bit of echoing, and then you go off. I think that's what's happening.
Yeah.
So
okay, now your point is well taken. All the drugs have some toxicities, and we need to very carefully look at that, as Colonel Chitalkar said. And this, I think,
it's just the inconvenience of a twice-a-day tablet with Nilotinib. That's all.
and taking it on an empty stomach. Sometimes it can be an issue with some people, right? So this is like the 5-year Dasatinib data. You can see that 5 years, both with respect to MMR and MR 4.5, Dasatinib is significantly better. Similar with 10-year Nilotinib, the major molecular response rates are significantly better. And this is with the before trial Bosutinib, again, exactly the same findings, higher MMR rates, higher MR 4.5 rates, and higher MR4 rates. And this again, I think a slide was shown to you earlier. You can see Nilotinib and Dasatinib, the significant gain in complete cytogenetic responses, major molecular responses at 5 years, deep molecular responses at 5 years, both with Nilotinib and Dasatinib, but no difference in overall survival. And so you have a choice of drugs, and I think the choice which drug, which Imatinib or which second generation TKI you start will also depend on how fit your patient is and what comorbidities the patient has, even in the first line, not only in the second line.
Hemant, can you just
Go ahead.
Can you take the voting of the panelists? If price of the Dasatinib and Nilotinib is same, what is their first choice, Dasatinib or Nilotinib?
Sandeep, Sandeep will do it when we meet face to face. This is difficult to do a polling on a Zoom meeting.
So, Dr. Sandeep Shah, the answer is simple. Dasatinib vocal for local.
So that is why I'm telling you prices are same of Nilotinib and Dasatinib.
Still Dasatinib, sir. Once a day tablet is easier.
Yeah. Okay, both of them have advantages and disadvantages. So, Shirish, this question is going to go up. You have to answer this question. So, please see the case carefully. We have a 28-year-old female, one child, and is desirous of more children, like standard high-risk CML, final diagnosis CML, CP, high focal risk. Now, here is the question. She was started on Dasatinib as per recommendations of Rahul, had a quick hematological response and a good optimal molecular response with minimal toxicity. 6 months from today, she had almost a major molecular response. She is on 8 weekly follow-up. And now when she comes to you yesterday, she tells you that her pregnancy urine strip is positive and her last menstrual period was 6 weeks back. So she has been exposed to a second generation TKI for about 4 or 6 weeks into the first trimester of pregnancy. Now, Shirish, what would be your advice for this patient? Should she continue pregnancy and also continue the TKI? Should she continue pregnancy, stop the TKI? Would you advise her a medical termination of pregnancy and after that is done, continue Dasatinib? Or would you choose something other than these 3 options? Shirish.
Yeah, thanks, Hemant. Firstly, I was surprised where you got my photograph from. I didn't know this photo existed at all.
So you can either fight or thank the organizers for that.
Okay.
They are in Ahmedabad only, you can beat them up.
Okay, yeah, sure. Okay, firstly, I'd like to say I don't deal much of with CML, mainly into solid tumors. But yes, in this case, I would ask the patient to, if she is not so much for, she wants to continue pregnancy, right? But if she has other issues,
she has one child, but she is desirous of one more child.
I would still counsel her that you better stop. Stop Dasatinib, or if she wants to continue pregnancy, just to stop Dasatinib. There's no other option then. Or the best option would be to do a termination of pregnancy and continue Dasatinib if the disease is a priority.
Okay. So fair enough. Your option of choice would be option 3. You would advise a medical termination of pregnancy, and once you're done with that, then you start the Dasatinib, right?
Right.
So I have Soumya online also. So Dr. Soumya is a senior consultant hematologist at Apollo Hospital in Kolkata. Dr. Soumya, what would you do? What of the 4 options you see on your screen would you advise for this patient?
Thanks, Dr. Malhotra. Basically, there has been case reports where pregnancy has successfully continued in spite of a patient being on TKI inhibitor. For example, there has been case reports of successful conclusion of pregnancy on patients with Imatinib. Now, the issue is here the child has been exposed early in the first trimester, and the lady is desirous of having another baby. I think that probably medical termination of pregnancy is too harsh course to follow. I will definitely discontinue Dasatinib, and I will probably opt for some other option which won't be that harmful for the baby. For example, if interferon, alpha interferon is available, I will probably prescribe alpha interferon. Let the pregnancy continue, deliver the baby, and once the baby has been successfully delivered, then probably return to Dasatinib. That would be my option.
Okay, so anyone of let me ask Dr. Lalit. Lalit, what would you do?
Yes, sir. Yes, sir. My option will be number 3, sir, MTP, which I will advise and then discuss with the patient. But my advice will be to go for MTP and then continue Dasatinib, and for subsequent pregnancy, we will ask her to do it in a planned way so that we can plan to stop the TKI before pregnancy.
Okay, so Shekhar, you work in a very fancy private hospital in Bangalore where you have lots and lots of rich, very aware, very literate patients who will not hesitate to take you to court in a minute. What would you advise?
Definitely, I would advise for MTP, and I will continue the Dasatinib, because here the risk of some amount of congenital anomalies are higher in the first trimester, which is exposed already 6 weeks are over. So I would definitely not take a risk of continuing the pregnancy at all.
Shekhar, can you speak up? We can barely hear you. A little louder, please, or a mic closer to you.
I would continue with I would stop the Dasatinib.
Shekhar, we can't hear you. Can you speak up, please? I know you're a very soft-spoken gentleman, but we have to hear you.
Can you hear, sir, now?
We can barely hear you.
I think some problem is the mic, anything there. I am very, very close to the thing, sir.
Now it is much better. I don't know what happened. It is much better.
I will advise for an MTP and continue the Dasatinib. I don't want to take any risk of having a congenital anomaly in the child under whatever, except because she can have one more child later on, and she is on Dasatinib. After 2-3 years, we can stop and go for one more conception. We can respect her views, but not with this continuing this particular pregnancy. I don't advise her.
Okay, so any other opinion, very, very briefly, because we'll do a 4th case and then we'll go to the question answers. Anybody has an opinion?
Yeah, I think I have some. So we have something data on Imatinib first trimester. Most of them they have used.
Dada, thoda sa jor se we can. I mean, we want everybody to hear you.
Hello, sir.
Yeah.
Yeah, yeah. One thing is with the Imatinib we have a clear-cut data. Even the first trimester with 400 mg, none of them they develop any complications. We presented data in ASCO. And the Dasatinib also they have some data, but think still the patient we have to explain pros and cons of this continuation of pregnancy. If nowadays we have the good imaging modalities, we can find out the congenital anomalies. So once we have to explain pros and cons, we can continue the pregnancy and first stop the Dasatinib. But we should be very clear in that. We have to explain in detail. Then only we can take the decision. The decision should be taken by the patient, not the doctor.
Okay, so I'll tell you my opinion, what I would do in a situation like this. You know, the chances of adverse fetal effect in normal pregnancies, which are not exposed to any teratogenic drug, is 1 to 2%. And with TKIs, I agree with Sada that the most of the data is with Imatinib, but also with second generation TKIs, this adverse fetal malformation incidence goes to 10 to 15%. The majority of these adverse fetal outcomes are stillbirths. So if there is a stillbirth, of course, it's a major psychological trauma to the patient and the family. But the remaining 5 to 10% of fetal abnormalities, which the patient and the family has to live for their whole life. And of course, this decision is the patient's decision and the family's decision. And there is a 80 to 90% chance that you can have a normal fetus also. But the unequivocal recommendation from our side should be an MTP. And if the patient chooses not to have an MTP, that should be very, very clearly documented in your case file. So, agar khuda na khasta, there is a fetal malformation, then at least you are legally safe. And I think what Lalita said is absolutely appropriate in this patient. We would try and discontinue this pregnancy and not discontinue the TKI for very long. And then subsequently after 1 or 2 or 3 years, then, use the TFR principles, which Hari told us, and then do a planned pregnancy. Okay, so I'll go to the last case quickly. What's happening? Why is my slide not moving? Okay, so this is a 48-year-old banker. The only thing different in this patient from our usual patients is that he had chronic renal failure. His urea is 98, his creatinine is 3.2, and the creatinine clearance is 28. And the ultrasound shows bilateral contracted kidney with loss of cortical or medullary dysfunction, a distinction suggestive of chronic renal disease. So you have a final diagnosis of CML-CP, high focal risk with CRF and a creatinine clearance of 28 ml per minute. Now let me start with Rahul. Rahul, how would you treat this patient? Which TKI would you give? Would you give standard dose? Would you give reduced dose? Which TKI you would not give? Rahul?
So if we have a renal dysfunction, is it audible?
Yeah, we can hear you. Go ahead, please.
So if it's a renal dysfunction, then the dose of Imatinib has to be reduced.
Okay. And what about the second generation TKIs?
So again, in a second generation TKI, not much of a interaction with the renal dysfunction. It is only with Imatinib which has to be done. I'm not sure about Bosutinib, but for Dasatinib and Nilotinib for sure, we can give the full dose.
Anybody has any other opinion on this? I had a patient a few weeks back like this, and I could not from my existing knowledge decide what to do with that patient. So I looked at the product information of all the 4 drugs. I show you that in the subsequent slide. Does anyone of my panel has an input on this? Samir, what would you do? Samir, are you there? Hello, Samir. Sandeep, you are the CML expert. What would you do? Dr. Sandeep Shah?
To be on safer side, I will start with Dasatinib 50 milligram because now 50 milligram data is also available, and to be on safer side with in chronic renal failure patients, I will start with Dasatinib 50 milligram.
Okay, so in the interest of time, I will go ahead. So this is the product information material which I am showing you. Imatinib is not excreted by the kidneys. Patient with mild to moderate renal dysfunction can be given low dose Imatinib, low dose meaning 400 milligrams, but with utmost caution and close observation. Patients who have severe renal dysfunction, creatinine clearance of less than 20, or who are on hemodialysis should not be given Imatinib. Now, Nilotinib and Dasatinib clinical studies have not been performed in patients with impaired renal function, and clinical trials with these 2 agents excluded patients who had a serum creatinine of more than 1.5 times the upper limit of normal. And even though the metabolites of these agents are not majorly excreted through the kidney, we do not have data on using these agents in patients with renal failure. So my take over here is that this is what the patient also gets to read. And if there is a worsening of the renal failure with one of these agents, even with reduced dose, at the moment it is difficult to recommend them. So my suggestion would be that you go with 400 milligrams of Imatinib and monitor it very carefully. Now, contrarily, for Bosutinib, the product information says that patients who have moderate renal failure can be given 300 milligrams of Bosutinib, of course, with careful monitoring. And even patients with severe renal failure, creatinine clearance of less than 20, they can be started on 20 milligrams Bosutinib with careful monitoring. So this is just some information for you to digest. Imatinib, mild and moderate renal failure, 400 milligrams per day with caution. Severe renal failure, do not use. Bosutinib can be given in mild renal failure, 400 milligrams, in moderate 300 milligrams, and in severe 200 milligrams. There is no data for Nilotinib and Dasatinib. So if you use any one of these agents, then you are on a bit of a legal limb as to if there is an adverse outcome, then it might be difficult for you to defend yourself. So any comments now from my panelists regarding TKI and renal failure? Any inputs? Okay, so this is my last slide. Like as already mentioned, CML patients now have a normal life expectancy, and this holds true only if expert management is provided to these patients. And it is our job, all of you who are leaders and experts in CML treatment, in hematology, in medical oncology, to make sure that you impart this knowledge and much more than this knowledge to everybody who's treating CML. If somebody is not treating CML, I think it is criminal negligence, and we have to convey to our young people, to some of the physicians who are treating CML, that you have to have a basic knowledge before you can do justice. And several options are now available in our country with the availability of generic, not so expensive second generation TKIs like Dasatinib. TFR is a reality, but it's a reality in a minority of patients, maybe 20 to 30% of patients. And the choice of TKI, not only in the second line, but also in the newly diagnosed patients, will depend on the cost, the convenience, as Rahul mentioned, the comorbidities which the patient has, and the toxicity. So with that, I'll finish my presentation. I will stop the slide share, and we will see if we can do some questions, okay? So is everybody around? We'll do some questions. So the first question is from Dr. Madhusudan, who wants to know TFR, and I think we've already talked about TFR, but he also wants to know which is the most effective drug in the accelerated phase of CML. So Pankaj, are you there? Dr. Pankaj? Okay, Pankaj is not there. Dinesh, I can see. Dinesh, can you answer this? Which is the most effective drug in accelerated phase of CML, and what dose also?
I think the accelerated phase will come into the high risk. So we should go for a second generation TKIs, considering the toxicity and the other criteria is met. So probably the second generation TKIs rather than Imatinib. And we should closely monitor for the response.
And a higher dose than the standard dose, right?
Probably the higher dose.
Yeah, Rahul, go ahead.
Sir, but Nilotinib is not approved for accelerated phase and a blast phase. Only Dasatinib is approved, sir. So Dasatinib 140 milligram.
Right.
I agree with Rahul.
So we have a question from Dr. Ruchika. How helpful is early molecular response assessment in predicting overall survival? So who wants to take this? Sandeep? Dr. Sandeep, can you take this? Sandeep Shah?
Yeah, I think most of the trials it is shown that if patients achieve early molecular response, that is less than 10% at 3 months, then chances of survival, overall survival will be high. And chances of getting deep molecular response also will be high.
Okay, so let me ask Samir. Samir, do you suppose you started a patient on Imatinib, and there is suboptimal response at 3 months? Say the BCR able is 15.55. It is not 10, not less than 10.
Yeah.
Would you change at 3 months, or would you give that patient a little more time on Imatinib?
Yeah, I tend to give them a little bit more time.
A little bit more time meaning a month, or you do the BCR able again at 6 months?
I tend to do it at 6 months. I don't do it straight away after a month, but we take the patient into confidence and get what the patient's views are. And if they're agreeable, I usually tend to do it again at 6 months and see what it is.
Okay. Dr. Soumya, what would you do? Rahul, I'm coming to you in a second. 1 minute. Dr. Soumya?
Yeah, I won't be changing my options just at 3 months. I will wait till the 6 months report.
Okay.
And depending on what the report is, I will decide.
Rahul, quick, crisp comment.
When it comes to overall survival, none of the trials, neither Decision, neither Earnest trial has shown any benefit of a second generation DKI in progression-free component. The only thing which they have been able to show by early molecular response is our ability to stop, your ability to reach to MR 4.5 at the earliest. That is the only thing which we need to remember. What is your criteria and what your treatment philosophy, that will decide.
Okay, okay, agreed. So I have a question from Dr. Narendra Agarwal, which I will direct to Dr. Lalit Mohan Sharma. What is your choice of TKI in a newly diagnosed patient of accelerated phase of chronic myeloid leukemia? This has been covered a little bit, but you can, do it again one more time, Lalit. Lalit, are you there?
So he has left.
He left.
Okay, so maybe Dr. Sadashivdu, are you there?
Only Dasatinib, so there's only one drug approved. It's a more efficacious drug, so definitely we'll go for Dasatinib.
Okay, so last question, maybe Rahul, you can take this. Any role of NGS for somatic mutation detection in patients of CML who do not have an optimal response in current real life practice in our country?
Sir, no, sir, we have started doing it. We have started sending samples, looking out for any other mutations which are there. I don't know what to do with that. But yes, if you're doing IRMA by an NGS, that will be a good idea. But looking for a somatic mutation is the area of interest which we are pursuing. Let's see.
Okay. So I think we've covered most of the questions also. If there are any comments by any one of the speakers or any one of the panelists, brief 5-10 second comments, we'll take those and then we will kind of try and wind up. Any comments from anybody?
So only comment is that you keep on conducting every week or every 15 days such debates, sir. It is so good to hear you and the panelists, sir. It is so much learning.
Thank you so much, Rahul. I thought it was, when Rajesh and the MCure people came and said one more webinar on CML, I was a little reluctant, but it's always a little bit of knowledge gain for me, so it's fun for me. And thank you very much for those nice words. So we have a score of 303 attendees in our meeting. I don't know what kind of woman that is. So 303 people attended this, and I hope they gained a significant amount of knowledge for this most common leukemia in our country. And when they see patients from the coming week, coming Monday, they will be a little wiser vis-a-vis their approach to the patient, what investigations to do, how to approach, what first-line treatments to give, which patient to think of for treatment-free remission, and particularly think of, anticipate and manage toxicities. With that, my most sincere thanks to MCure for facilitating this, for Rajesh, Kalpesh and his team at Mice Ideas for organizing this, and for my faculty for wonderful talks, and for all the delegates who spent their Friday evening with us, and I hope they learned something. So I'd like to hand over proceedings for the final conclusion to Mr. Sanjeev Katuria. And Sanjeev, can you be very brief and wind up? My apologies for overstepping about 30 minutes into extra time. Sanjeev?
Thanks a lot, sir. And on behalf of MCure, I would like to extend my sincere gratitude to all the honorary faculties as well as the delegates. As rightly said by you, sir, almost 320 delegates have logged in for this webinar and making it a very interactive and informative session. Thanks a lot once again. And now over to you, Zoe. You can give the vote of thanks. Thanks a lot.
Thank you so much, Anjali. I would like to thank Hemant Malhotra, sir, for such a nice scientific and academic speech. Would like to thank the entire panelist who we had such a great interaction. And as an MCure, we would continue to have more such events, more both especially in the field of hematology and other. And I would also like to inform that with the promise we would have an event tomorrow as well, especially on the role of Cidofovir. So stay tuned. We can connect. You can get in touch with the local people, and My Ideas team is always there. So thank you, My Ideas team as well. And again, sir, thanks a lot, Dr. Hemant Malhotra, for making it such a successful event. So thank you.
So thank you, my speakers, and thank you, my faculty. We'll see you soon. Thank you. Good night. Enjoy the weekend.
Good night.